criteria. So I guess the first question is, there's 3 criteria. How many of them need to be true to give you a diagnosis of pancreatitis? Do you need all 3? Do you only need 2? Do you just need 1? 2. Very good. And could you give me one possible of the 2? Mm-hmm. That's okay. Amylase and lipase. Yeah, very good. So amylase and lipase elevation is one of the 3 criteria. And typically the exact elevation you're looking for is greater than 3 times the upper limit of normal. And so if the upper limit of normal of lipase is 60, I don't know what it is, to be honest, but if the upper limit is 60, then you would be looking for greater than 90, right? 3 times whatever the normal is. That's really more step 2CK that you need to know that particular fact, but just knowing that having an elevation in amylase and lipase means you should be looking for pancreatitis, I think is good for step 1. Okay, so that is one of the 3 criteria. A second of the 3 criteria is what you are seeing here. So any sort of imaging findings that are consistent with pancreatitis. And so here you can see very clear imaging findings that are consistent with pancreatitis. Okay, so that would be 2 criteria, and we would be good to go. The last criteria, if you didn't have the imaging findings, if all you had was amylase and lipase, you want to prove it's pancreatitis, the last criteria you would go for is actually the clinical presentation of a patient. And so what sort of pain do patients have when they have pancreatitis? It's a very specific thing, I told you, that nothing else really presents this way. Excellent. Very good. Yes. Epigastric pain that radiates to the back is very specific for pancreatitis, very helpful for getting you to that diagnosis. Very good. And so any 2 of those 3 things can give you the diagnosis. And we talked about chronic pancreatitis, where you're really looking for those alcoholic males, and pancreatic pseudocysts, any sort of trauma to the pancreas, acute pancreatitis, chronic pancreatitis, any sort of, inflammation of the pancreas itself can lead to a pseudocyst. Pseudocysts in general are, pretty benign. They may cause a little bit of discomfort for your patient, but otherwise it's not something that is really deadly or something you're too worried about in general. Okay, great. So carcinoma of the pancreas, very important topic here. We've seen, especially recently in the news, Alex Trebek came out and said that he has stage 4 cancer of the pancreas. One of the Democratic congressman, his name is Elijah Cummings. It came out that he has stage 4 pancreatic cancer, and the problem with pancreatic cancer is that there's not a lot of symptoms, and so patients usually present once it's a very advanced stage. So let's talk a little bit about that. So carcinoma of the pancreas, we really do look for older patients, and this is going to arise from a non-invasive precursor lesion. If there was some way to detect this lesion, we would be able to prevent 99% of pancreatic cancer. The problem is, a lot of times, these are in the small ducts of the pancreas, and we really have no idea. There's no way to know that there's these tiny little lesions growing in the pancreas. There's no nerves there. It's asymptomatic. Okay. So those little non-invasive precursor lesions, they become invasive, they end up metastasizing, or they end up just sort of growing and causing a lot of problem to the local structures there. The stomach and the aorta, especially being 2 of the areas that are affected. So risk factors here, cigarette smoking is huge. Of all of your risk factors, I really like you to put a star by this one, because this is the one that they ask you about in terms of risk factors for pancreatitis. They ask you about cigarette smoking. So you got to know that one. High fat diets, chronic pancreatitis. These patients that have repeated bouts of pancreatitis have a higher risk, obviously. Diabetes, especially type 1, where you have all of those autoimmune cells in there destroying parts of the pancreas that leads to inflammation. Inflammation can lead to cancer. Okay, and so again, the big problem with pancreatic cancer is these usually remain silent, until there's some impingement on the local structures. So if it is in the head of the pancreas, just sort of as a review of our pancreatic structure, this is the head of our pancreas, this is the body, and this is the tail, okay? And so the exact cutoff is not really important between the body and the tail, but generally, you consider this the head, and this is the body, and this is sort of in the tail region. Now, there's a pretty important structure that passes through the head. What structure is that? It passes through the head on the way to the duodenum. On the way to the ampulla, to be specific. I'll draw the rest out here. Here's our gallbladder, right? Good. So this is going to be our common bile duct. Once all the bile ducts join together, we just call it common bile duct. And so when you start having a tumor growth here in the pancreas, the patient is going to present as if they had a stone in the common bile duct. Okay? So will they have jaundice or no jaundice? Yes, jaundice. Excellent. They are going to really present giving you a complete, stone in the common bile duct picture. Okay? And so obstructive jaundice, giving you dark urine, light stool. This is because instead of our bilirubin being excreted through the GI tract, right? Because the liver is making all this bilirubin and trying to pass it. The bilirubin cannot pass into the GI tract anymore. And so the bilirubin is going to be reabsorbed back into the blood supply and end up leaving through the urine. Okay, and so in these jaundiced patients, look for dark urine, light stool, and the stool is relatively lighter because of the lack of bilirubin there. And then, so that actually is a good thing. If you have a patient that presents with this obstructive jaundice, this is a nice thing because they come to the hospital, we do some CT scan, we see the tumor, maybe we can take it out before it gets too big. It's actually a good thing that these patients get obstructive jaundice because when you think about body tumors or tail tumors, what sort of symptoms are they going to have? Zero symptoms. If you have a tumor growing back here, there's nothing to obstruct except really the pancreatic ducts, and so maybe you'll have a little bit of malabsorption, but you still have all these downstream ducts, so these ducts are fine, so it's not going to be a lot of malabsorption. So really, your patient is going to have zero symptoms. This tumor is going to grow and grow and grow and grow. It's going to start invading some of these local structures, the spleen, adrenal glands, transverse colon, stomach, inferior vena cava, aorta, celiac trunk, right? All of these local structures are going to get involved. And then when you do a CT scan, you're going to see a tumor that starts in the pancreas and it has its fingers growing into every single organ around it. Okay, and so in order to cut that tumor out, you're going to have to cut out part of the stomach, part of the adrenal gland, part of the aorta, part of the SV, right? So, this amount of tissue you would have to take out is really not going to be compatible with life. And so your patient just went from being completely fine, asymptomatic, to being terminally ill with cancer and a few months essentially from death. Okay, and so this is a very, very scary, very bad prognosis. Okay. So if you do have that tumor in the head of the pancreas, you're going to look for the obstructive jaundice. The other thing I want you to look for is a distended, this should not say non-palpable, this should be a distended palpable gallbladder. Distended palpable gallbladder. Because as this is blocking everything coming down the common bile duct, the gallbladder is going to start to get bigger and bigger. And so you're going to be able to feel the gallbladder, but the gallbladder will not be painful. Non-painful. Okay, this is not cholecystitis. Right? This is not the gallbladder contracting against a stone. This is the gallbladder becoming distended because of a downstream obstruction. And so when you see this distended, palpable gallbladder that is not painful, you really need to have your suspicions high for a pancreatic cancer. Okay? This is, I'm going to put a star by this because this is one of the signs that they may give you in a question stem. Other things, so more of a paraneoplastic syndrome you can think about is this Trousseau's sign. And what Trousseau's sign is a migratory thrombophlebitis. So let's break that word down. Migratory meaning it's going to move throughout different parts of the body. On one day it's going to be in the arm, next day it's going to be in the leg, next day it's going to be in the kidneys. And thrombophlebitis. All thrombophlebitis means thrombus formation in the veins. In the veins. Thrombi in the veins. Okay? And so, Trousseau's sign is thrombi in the veins that goes to different parts of the body. And so your patient will say, you know, the other day I had this really hard thing in my arm that was kind of painful. Then it went away. And then yesterday I got a really hard thing in my leg, on the surface of my leg that was a little bit painful. And then it went away. And then now today right here in my neck, I have a really painful thing. Even though the other painful things went away, I have a painful little mass here. And so seeing these, you know, the patient doesn't know that it's a thrombus, right? They don't know that it's essentially a DVT, or not a DVT, but a SVT, a superficial venous thrombosis. They don't know that these are venous thrombi. They just know that there are little painful masses under their skin. And so this is what they're going to tell you. They're going to tell you, I have a mass in my arm, it went away. And then the week later, I had a mass in my leg, it went away. So not a lot of things present that way, right? Usually if patients get a mass, the mass stays. And so if they start, you know, saying something like this, think about maybe these little masses are thrombi that are forming, and it is associated with pancreatic cancer. So definitely we want to have our suspicions high for that. In terms of the mutations that lead to pancreatic cancer, this is the most important one I'd like you to know. CDKN2A. CDK is one of those cell cycle regulators. And so, you know, you have a mutation here that causes the cell cycle to start cycling out of control. We lose the brakes on the cell cycle. And that is our CDK. That's the role of CDK. And so this mutation is highly associated with pancreatic cancer. So please, please, please memorize this one. KRAS, you see this in a lot of tumors. TP53, you see this in almost every tumor, right? This is probably the most common one. You know, they're good to know, but they don't have as strong of a specific association with pancreatic cancer as CDKN2A does. So memorize this one. Know these ones, great, but memorize this one for sure. Okay? Okay, great. Any questions on pancreatic cancer? No? Okay. And I don't have any questions for you either. You got lucky on that one. So breaking down the conditions we've just talked about. Acute pancreatitis, for females, we think of cholelithiasis. So essentially a stone in the common bile duct that is obstructing the ampulla of Vater, that is not allowing pancreatic enzymes to leave the pancreas. Those enzymes stay in the pancreas. They cause pancreatitis. Great. Alcohol is toxic to the pancreas, so males, they drink too much alcohol and then they get pancreatitis, okay? Epigastric pain, radiating to the back, you told me all about that. And then lab studies, elevated amylase lipase, you told me about that too. Great. NPO is the treatment. Again, this is getting into step 2CK. Don't really need to worry too much about what, you know, exactly the treatment is right now, but it's good to talk about getting your mind kind of already progressing towards that goal. Restore fluids, and we are going to give, and since we're putting our patients NPO, we need to give them IV alimentation, IV sustenance, essentially. They'll be getting TPN for food, okay? Great. Chronic pancreatitis, we're really thinking about these smokers. Here we see everything that we see in acute pancreatitis plus fat malabsorption, aka steatorrhea, fatty diarrhea. Okay? And then pancreatic neoplasm, here we will see some abdominal pain possibly, although the problem is, again, oftentimes we don't see any abdominal pain. If that tumor is in the head of the gallbladder, we can see jaundice. We can did I say head of the gallbladder? Head of the pancreas. We would see jaundice, a palpable gallbladder. This is aka Cavassier's sign. When you have a palpable gallbladder that is not painful, it's called Cavassier's sign. And yes, so that's if it's in the head, and surgery would be the treatment there. Okay. Excellent. So, moving on to the liver, in general, our signs of hepatic injury, we can have different types of hepatic injury. This is kind of getting into the pathology, what you see when you look under the microscope. And so when you see inflammation, we call this hepatitis, right? Any itis is an inflammation, and hepa is our liver. So it can be an autoimmune hepatitis, could be drug-induced, could be caused by viruses, could be caused by some sort of weird worm crawling in there, our entamoeba histolytica, these parasites that grow into our liver. It could be an abscess due to some sort of bacteria, although very rare. That's another possibility too. So those all sort of cause an inflammatory type picture. Degeneration of the liver is described as ballooning of those hepatocytes, where you see swollen hepatocytes, watery cytoplasm, and you see foamy cells with bile inside of the cell. That's why it looks foamy. And some fatty change inside of the cells as well. And so, I put a star here because you do get questions on microvesicular versus macrovesicular fatty change to the liver. And so you need to know which is associated with which. So microvesicular fatty change. That means that here's our hepatocyte, right? This is our liver cell. We're having degeneration of our liver cell due to fat. You can either have tiny little vesicles filled with fat in your hepatocyte. This is our microvesicular. Or in your hepatocyte, you can have giant vesicles filled with fat. Okay? And that is our macrovesicular. So for microvesicular fatty change, this is Rey syndrome. This is, your child who takes aspirin when they have a viral illness. They can develop Rey syndrome, right? That's why we don't give aspirin to children. Macrovesicular, we associate with alcoholic and non-alcoholic fatty liver disease. Okay? So your alcoholics are going to have macrovesicular. Children have microvesicular. So the way you remember this, and I think it's going to be obvious to you now, is that children are kind of micro, they're small, and so they get microvesicular change. They get Rey syndrome, and so we see those microvesicular changes, versus when you want to drink, you have to be older. So that's macrovesicular. Macro is big. And so if you want to drink, you have to be older, and so that's where you see the macrovesicular fatty changes. Okay? And I do see questions on that, so maybe you'll have one question on your whole exam about it, but it's still something that's kind of nice to know, and might help you down the line. Who knows? Fibrosis of the liver involves bridging. Bridging is essentially, along your portal tracts, you get a bunch of connective tissue that gets laid down in your liver. And so you remember when we talked about how we have a portal triad, that portal triad is going to empty into the hepatic vein. And then at each corner of the liver acinus, we have another portal triad that's emptying towards the hepatic vein, another portal triad. Does this ring any bells? Right? With the structure of the liver, what it looks like under the microscope? Maybe a little bit, no? So essentially, in the liver, we have the structure is something called an acinus. This is called an acinus. Okay, and the acinus is going to kind of direct the flow of blood. The liver's job is to clean blood, and so we have the portal vein here, which is bringing blood from the GI tract. We have the hepatic artery, which is bringing oxygenated blood to the liver. And then we have the hepatic duct, which is taking bile away from the liver. Okay? But all of the blood flow from this portal vein and from the hepatic artery, all of that blood flow is passing towards a central hepatic vein. Okay? It's all moving in this direction. As it moves in this direction, it's passing by a bunch of hepatocytes. These liver cells are lining the area where blood is passing. And so as the blood passes, these cells will clean the blood. They will take out any toxins. They will, if there's glucose in the blood, they will process that glucose, get it ready for transport to the parts of the body that needs it. It'll work through any proteins. It'll work through any fats that are there. That's the job of the liver, is to metabolize everything from our diet. And so that's why we have this structure in the liver, so that all of the blood coming to the liver gets nice and cleaned and metabolized by these hepatocytes, and then it all dumps into one into one hepatic vein that will go into the inferior vena cava and then go back to the right side of the heart. Okay? So that is the structure of the liver. That's the normal structure of the liver. In hepatic fibrosis, when you get fibrosis of the liver, what ends up happening is you get bridging of portal tracts with connective tissue. And so instead of having this nice portal tract where it's going from this portal triad towards the hepatic vein, you're going to have laying down of a lot of, let me use another color here. You're going to have laying down of a lot of fibrosis in this area. And that fibrosis is going to make it difficult for blood to move in a nice orderly fashion, you can imagine, right? If it's having to pass through all this connective tissue. And so this is what we see with fibrosis, is bridging of the portal tracts. Okay, and ultimately, in our cirrhotic patients, our patients with cirrhosis, this is what their liver looks like. They have bridging fibrosis of their portal tracts. Okay, dense fibrous tissue and regenerative nodules of hepatocytes. In any of these conditions, you will have an elevation of ALT and AST. However, depending on the cause, the elevation will be different, right? I'm sure you've heard this before. The ratio of ALT to AST is going to sort of point you in the direction of what the cause is. For example, if you have an AST that is double 2 times the ALT, if the AST is 2 times the ALT, that clues you in that your patient may have alcoholic hepatitis. Okay, if the AST is double the ALT, I don't care what the numbers are, 400 and 200, 800 and 400, 150 and 75, right? I don't care what the numbers are, but if the AST is double the ALT, think about alcoholic hepatitis. Okay? Now, if the AST and ALT are both elevated into the thousands, if AST and ALT are increased into the thousands, I'm talking 1,500, 2,500, 4,000, 8,000. If they're anywhere in the thousands, think about viral hepatitis. Increased to thousands, think about viral hepatitis. Okay, here we're having a virus that's really busting open these hepatocytes, and those hepatocytes are releasing everything inside. And so here we don't really look at the ratio, right? I don't care that the ALT is 4,500 and the AST is 3,600. They're both elevated into the thousands, and so all I care about is that they're there in the thousands. I'm thinking about viral hepatitis. Okay, versus that example that we use for alcoholic hepatitis, typically that's not going to be in the thousands. Typically it'll be in the hundreds. So an AST of 800 and an ALT of 400 would clue you into alcoholic hepatitis. Okay? Great. So kind of changing gears here, talking about our hereditary hyperbilirubinemia. You and I both know they love asking about this. Krigler, Najjar, Dubin-Johnson, Rotor, Gilbert. Oh my goodness, they can't get enough of it. So let's talk about it. The first one, before we talk about everything, let's talk about normal. And so normally, inside of our hepatic sinusoid, we have our circulating hemoglobin. This is where all the blood is passing by. Remember that acinus that I just drew for you? And so here would be our portal triad. Here's our portal vein. Here is our hepatic artery. Here's our cystic, our hepatic duct. And here is the hepatic vein where all the blood is dumping into. And so blood is moving from the portal vein towards the hepatic vein. Blood's moving from the hepatic artery to the hepatic vein. As it's passing, we're going to have circulating bilirubin in the blood. And part of the job of the liver is to take out any of that bilirubin. That's a big, big job of the liver. And so bilirubin will be taken up into cells. Those cells will conjugate unconjugated bilirubin to conjugated bilirubin. Great. We love conjugated bilirubin. Why? Why do we love conjugated and we don't love unconjugated? What is not so great about unconjugated? right? Why do we have this process? Why do we care if it's unconjugated or conjugated? It's essentially, you do know, I promise you do. Unconjugated bilirubin is not water soluble. Okay, unconjugated bilirubin is the bilirubin where the example that I gave you was we take a glass of water and we drop some sand inside of it, right? What is that sand going to do? Is it going to mix with the water, or is it just going to fall to the bottom of the glass? It's going to sink to the bottom of the glass. When we pour out that glass of water, the sand is still going to be in the glass, right? You can picture that, the sand still being there in the glass, even though that we poured out the water. What does that mean? That means that the unconjugated bilirubin is the sand, okay? And the water is our bloodstream. And so when that water reaches the kidney, we want to get rid of the bilirubin. But it is sand. It's not going to leave through the kidney. It's not water soluble. Okay. And so the liver has this really nice process where it conjugates it to another molecule that makes it water soluble. Now, instead of putting sand into a glass of water, now we're putting sugar into that glass of water. Sugar is going to dissolve oh so nicely. When we pour out that glass of water, the sugar is going to be gone too. Okay. So conjugated bilirubin is our sugar. Unconjugated is our sand. Okay. And so, we conjugate it, now it's water soluble, and now we can get rid of it through the bile. It's going to leave from the bile. Some of it gets reabsorbed and will leave through the kidneys because now it's water soluble. Great, that's what we want, right? And so that's really the goal. Now, so I've explained to you why it's good to conjugate it, because then we can get rid of it. Why do we need to get rid of it? So unconjugated bilirubin, aside from the fact that it doesn't leave the body, it also will start building up in places and cause big problems for our patients. Okay. One of the places that it builds up is in the basal ganglia of the brain. The basal ganglia. And you know, whenever you hear basal ganglia, I mean, it sounds pretty important, right? Who knows what it does? It sounds important. So we don't want unconjugated bilirubin building up there. Okay. If you have unconjugated bilirubin building up in the basal ganglia, that leads to something even worse called kernicterus. Okay. And kernicterus sounds even worse. It sounds like the bad guy in the movie, right? Kernicterus. It sounds like a villain's name. And so kernicterus is very, very bad, especially in our newborn babies. This is why we watch bilirubin levels in newborn babies, because we don't want them to develop kernicterus. Okay, so we have this beautiful system, though, where we take up any unconjugated bilirubin, we conjugate it, and then we can get rid of it. And so the last thing we have to talk about in terms of normal before we move on is what is the enzyme that does the conjugation. I mentioned before when we were going through anatomy and physiology that this is one enzyme that you got to know. It's called UDP glucuronylyl transferase. UDP glucuronylyl transferase. And you can see that enzyme right here. That enzyme is going to be what converts unconjugated bilirubin to conjugated bilirubin. This enzyme takes sand and turns it into sugar. That's pretty freaking amazing. So great. So as long as we have this enzyme, we are going to be good. It's going to convert it to conjugated. We'll be able to get rid of it through the bile and ultimately through the urine. Really, really nice. Now, what happens when we have decreased levels of that enzyme? Let's talk about it. So Gilbert's syndrome is going to be the first condition we talk about. And the primary problem here is a mildly decreased UDP glucuronylyl transferase conjugation. That's the major problem. Right here at conjugation, the levels of this enzyme are lower. Our baby has less of this enzyme. Okay, so what does it look like? Asymptomatic for most of the time. If your patient has fasting, if your patient has stress, yes, now we may get a little bit of jaundice. Okay, however, otherwise we are not going to have a lot of big symptoms. Okay, this is actually pretty common, not a lot of clinical consequences. We're not really worried about kernicterus too much in these patients because they still have enough of this enzyme, UDP glucuronylyl transferase, to get by. Okay, so they don't have a lot of problems. They don't have a lot of symptoms. Okay, and so that's the first step. They also have an issue with taking bilirubin out of the bloodstream. It's less of a part of the clinical picture. More, I'd like you to remember that it's this mildly decreased enzyme, but yes, also the uptake of bilirubin is also decreased. This is decreased, and conjugation is decreased. Okay, both of those are going to be decreased a little bit. So that's our first clinical condition when we have a little bit of decreased activity of this enzyme. Now, what if we get rid of this enzyme altogether? Absent UDP glucuronidyltransferase. This is when we get the Krigler-Najjar. Krigler-Najjar, right? It sounds like this another villain from a movie, Krigler-Najjar, and his friend Carnicterus are bringing big problems to our newborn babies. And so what we see is because we completely eliminate this step, unconjugated bilirubin is going to be through the roof. That unconjugated bilirubin is going to build up in the basal ganglia. Our babies are going to end up with kernicterus, and it ends up being a fatal, unfortunately. Patients die within a few years. You can sort of delay death essentially by using plasmapheresis, cleaning the plasma of any unconjugated bilirubin that's there. Phototherapy will temporarily turn this unconjugated into conjugated, but it's a temporary measure. It you have to keep the baby under the light forever essentially, and that's just not feasible. Okay. And so that's our Krigler-Najjar. Not good, not a good thing. Okay. So this is the one that you really got to know. No, Krigler-Najjar is associated with absent UDP glucuronidyltransferase. This is an enzyme where before this lecture, maybe you wouldn't have even been comfortable pronouncing this. By the end of this lecture, I want you to know this enzyme like it's the back of your hand. Okay, I want you to be able to close your eyes and see this word in front of you. Do it right now. Close your eyes and see UDP glucuronidyltransferase. Okay, know this enzyme. When you see it in the answer choices for your questions on step 1, you're going to know exactly what it does. And the way they're going to ask you about it is always going to be in this context, talking about these babies or these, and Gilbert can be a little bit older, patients that have decreased activity of that enzyme leading to elevated unconjugated bilirubin, right? Just imagine these babies have all the sand building up inside of their veins, and this is a big, big problem. Okay? UDP glucuronidyltransferase. Okay, I'm going to move on now. Dubin-Johnson syndrome. Here, the problem is not with conjugation. Conjugation is fine. Unconjugated bilirubin is at its normal level. The problem here actually is due to getting that conjugated bilirubin out of the liver. Okay, it doesn't want to leave. It wants to hang out. And so we get a conjugated hyperbilirubinemia, high levels of conjugated bilirubin due to defective excretion. So what is the big thing we got to know here? A grossly black liver. Okay. And so you really will only find this out after your patient dies and you do an autopsy. You open up the abdomen and you say, oh my God, this man's liver is black. Okay. And so it's completely benign, really no symptoms at all. Okay. And then the last one that you can be asked about is something called rotor syndrome. Same exact thing, except no black liver. Oh my God, that is so easy to remember. Okay. Same exact thing, just no black liver. All right. So in terms of which you should study, for which you should focus on when you're studying, really memorize these two well, Gilbert's and Krigler-Najjar. Know that Gilbert is, relatively benign, although you can have some jaundice. Krigler-Najjar is deadly. And these are the two I really want you to be comfortable with. Dubin-Johnson, completely benign. You just have a black liver. Rotor, completely benign without even any black liver. Okay. And so those are the things I want you to know. I also would like you to be able to, if you were to be given this image, which happens to be from your first aid book, it's a really nice image. If they were to give you this image, be able to label this image where each of these hereditary hyperbilirubinemias takes place. Okay. So putting, Gilbert's sort of up on this part versus putting, Dubin-Johnson rotors down here, sort of having that understanding at a really good level is helpful. Okay. And so I already know, you don't even have to tell me, this is a subject area, a topic that was always confusing. Whenever you got questions, they were always confusing. But now after I've explained it, it's much more clear, right? You don't have to tell me. I know because I went through this stuff and it was tough. So does this make sense? Do you have any questions? Anything that you want me to go over again? Okay, good. So again, moving on to jaundice, we've mentioned jaundice about 1,000,001 times so far in the past few lectures. What exactly is it? And so the things you already know: yellow discoloration of skin, with the early sign of jaundice being yellow discoloration of the sclera. Sclera is this white part of the eye. Okay, that's the part that's outside of your iris that gives you that beautiful color of your eye, and the white part, it turns yellow. That's sort of the first thing that happens in jaundice. Okay, sometimes I feel like I've seen a question on that before, so good thing to know. That's the first place you check for it. Second place you can check is inside of the mouth, believe it or not. Due to an increase of serum bilirubin, usually over 2.5 milligrams per deciliter. Okay, and so the normal limit of bilirubin, whenever you ask for your lab to run a test on bilirubin, what they give you is two numbers. They give you your total bilirubin, and then they give you your direct bilirubin. Okay, and so your total bilirubin is the total amount of bilirubin in your body. It includes your unconjugated and conjugated bilirubin. Okay, and so usually for total bilirubin, you want to see a number that's less than about 1.4. Actually, I think 1.2 is the upper limit, but let's just say 1.4 for now. Okay, whatever the number is, it's going to be on your on your lab value sheet, so you would be able to look it up anyway. Okay, if I'm telling you the wrong thing, which I don't think I am. So they'll give you the total bilirubin, and then they will give you the direct bilirubin, which is usually about half of whatever the total bili is. And so upper limit of direct, really the maximum that you would want to see is 1.0. Okay, and so say we did this. We did our total bilirubin, we got our direct bilirubin, and the numbers come back as 1.1 and 0.5. 1.1 being our total bili, and 0.5 being our direct bili. Okay, now I have a question for you. If these are the numbers, what is the value of my conjugated bilirubin, and what is the value of my unconjugated bilirubin? Excellent. Very good. Unconjugated is 0.6 and our conjugated is 0.5. Excellent. Very good. And so sometimes they ask you to do this math. This math is also very important because if you have a patient that has, let's do another patient, right? We're going to go on to a new patient. Let's say we get our direct bilirubin back and it's 0.5 and our unconjugated bilirubin is 6.1. I'm sorry, our total bilirubin is 6.1. I was going to ask you what our unconjugated is then. So our unconjugated would be like 5.6, right? So if you have an unconjugated bilirubin of 5.6, what might be wrong with your patient? Excellent. Good. And I love that you said the conjugation is bad. You didn't say UDP glucuronidyltransferase. That's one possible cause. But what's another possible cause? Liver failure. If your liver has completely died, essentially, it's not going to be conjugating anything for you. So you're going to have unconjugated bilirubin building up in the blood. Okay? Great. So, there's a lot of different causes that can lead to high levels of unconjugated bilirubin. Okay? But they all involve the ability of the body to conjugate. Could be a problem in the enzyme, could be a problem in the in the liver itself. You don't really know until you do more tests. So great. So that's another possible case. And then let's just do one more case. Let's say we get our total bili back. It's 6.1. And then our direct bili is 3.5. Okay. And so what could be going on here? My goodness. Yes. Of the common bile duct, right? Yes, excellent. Very good. Killing it today. So, obstruction of the common bile duct is going to cause elevation of everything that's supposed to be excreted. And so that is definitely something that you can see. So great, excellent obstruction. And then the other thing I would like you to consider is any kind of hemolytic state. And so anytime your patient has increased breakdown of their red blood cells, that is going to cause an increase in the amount of bilirubin overall in the body. And so, the liver is going to be conjugating that as fast as it can, but that bilirubin is going to start to accumulate a little bit. And so although the liver is doing everything it can, because of such high breakdown of red blood cells, there's just so much bilirubin to deal with that that levels can start to increase a little bit. Okay? So good. So obstruction and hemolysis would be the two cases that I'd like you to think about there. Okay? Excellent. Very good. Very, very good. And so here we kind of go through our normal bilirubin metabolism. Is there another image here? No. But we talked about this already, right? Albumin carrying it and all of the steps here. So great. Next, we can talk about here are some diseases that cause increases in conjugated bilirubin, extravascular hemolysis, ineffective erythropoiesis. Again, any kind of hemolysis, we would see elevation in unconjugated bilirubin as well as conjugated bilirubin in a lot of cases. And you want to keep in mind that there is that risk of bilirubin gallstones. These are going to be our gallstones that have calcium in them. We see them on X-ray, and there are black stones versus you have yellow stones of cholesterol, and then the black stones of bilirubin. These would be our black stones. Physiologic jaundice of the newborn. Here, when we, when it comes to newborn babies, they have low levels of our UDP glucuronosyl transferase. That is just part of being a baby, okay? Their baby's liver, it doesn't have all of the enzymes really ready to go. All that machinery is not quite ready to go yet. That includes that enzyme. And so it is normal. It's physiologic for babies to get a little bit jaundice. And I think that we're comfortable with that idea. So if that unconjugated bilirubin starts to get very high, we do need to do phototherapy. That phototherapy makes unconjugated bilirubin water soluble. It turns it into sugar. It allows it to leave through the urine. Because if it starts to get too high, we worry about kernicterus. Okay. Gilbert's, again, mildly low UDP glucuronosyl transferase. Quirigler-Najjar, very, very bad. Dubin-Johnson, we look for a black liver and elevated conjugated bilirubin. Rotor being the same thing, but lacking that liver discoloration. Biliary tract obstruction, you told me this already. Elevated conjugated, elevated unconjugated. Also look for elevated ALK phos. ALK phos is in the lining of the cystic duct, the lining of the hepatic ducts. All of these ducts that carry bile have ALK phos in the cells that line them. They all have ALK phos inside. And so any sort of obstruction that's causing inflammation in those cells will lead to elevated ALK phos in your patient's bloodstream. So that's something to look for. And last, viral hepatitis. We essentially have liver dysfunction when you have viral hepatitis. So look for elevated conjugated bilirubin and elevated unconjugated bilirubin. Okay. So viral hepatitis, we essentially have liver dysfunction here, and so we will have elevations mostly in unconjugated bilirubin because we lose the ability to conjugate, but you'll also see some conjugated bilirubin as well because the liver's not really that great at excreting it either. Okay, great. Getting into our viral hepatitis, I'm about to start asking you about some HBS AG, HBS AB, so be ready for that, right? Viral hepatitis, inflammation of liver parenchyma. This is typically due to our hepatitis virus. So hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E are our usual suspects. Although EBV and CMV can less commonly cause hepatitis. Hepatitis viruses cause acute hepatitis, which can progress to chronic hepatitis in some cases, depending on the virus. And acute hepatitis, know what it looks like. Know what the symptoms of acute hepatitis are, because I feel like it took me a long time to learn that. Like I was still getting confused about acute hepatitis even when I took step 2. It's kind of embarrassing to say, but you won't make that mistake. So jaundice, dark urine, and then also look for fever, malaise, nausea, vomiting, and a painful liver. When you palpate their liver, they're going to have discomfort in that right upper quadrant. Okay, and so that fever, nausea, vomiting with jaundice is typical. Okay, with that right upper quadrant pain. And for acute hepatitis, we look for less than 6 months of symptoms. Chronic is anything greater than 6 months, and you have that risk of progression to cirrhosis. If you have cirrhosis, then you have a risk of hepatocellular carcinoma. And so that's the other thing you should be worried about. Okay. So here's what our acute hepatitis looks like on histopathology. It doesn't really look like anything. I'm going to be honest with you, Natalia. I mean, what does this look like? This looks like spaghetti. What I'd like you to see here, essentially, there's a couple things. Let me change the color of my pen first so that I can actually point at things. Okay. It's not letting me change the color. Here we go. Okay, good. So a couple things. First, notice these round red bodies. These are called Councilman Bodies, and they're essentially, as your hepatocytes are dying and your hepatocytes are, getting a lot of inflammation, they everything inside of them kind of coalesces into one giant bubble, and that is what we call a Councilman body. And so if you ever see this term, think about acute hepatitis. Kupffer cell hyperplasia. We said the Kupffer cells are the macrophages of the liver. They are the macrophages of the liver. And so if you have a viral infection, expect to see an increase in the number of macrophages. That makes sense. Okay. Inflammation around the portal triad, lobular disarray. And so, even looking at this picture, one of the reasons it's so hard to see what you're even looking at is because you don't have that nice architecture I was telling you about earlier. You don't really see the acinus. Maybe here you can kind of see where there used to be an acinus a little bit. But it's very hard to tell because as the liver gets all this inflammation, it loses its architecture. Okay. And last thing I want you to notice, if you see all of these little purple cells here, these are all lymphocytes that have come into the liver to try and fight off the virus. Okay. Normally you don't see a lot of these little blue cells coming in. Those blue cells are white blood cells. Okay. So that is our histology. Let's talk about our different kinds of hepatitis. And so this is a nice chart from Pathoma. I'm not sure if you use Pathoma in medical school, but it was very helpful for me when I was going through medical school. And some of the charts I still like using, and so I just blatantly ripped it off. That's okay. We're not going to let them know. So going from hepatitis A all the way through to hepatitis E. So which of these are going to be fecal oral transmission? Which of these are going to be blood transmission or fluid transmission? I'm sorry? Yes, I'm asking you. Which one's fecal oral? We have A, B, C, D, and E. Go ahead. A and E, very good. Okay. B and D, good. And what about for like sexual transmission? B big time. I really want you to think about B big time for sexual transmission. D can be as well, but B is the one that's more common, I guess, and the one that I really want you to focus on being sexually transmitted. Okay, good. What about needle sticks? C, good. Okay, what about tattoos? C, because that's a bunch of needles sticking you over and over, right? Yeah, good. Awesome. Okay, so now I'm going to get into the tough questions. Those are all easy questions. Which of these are going to be acute, tend to be acute, and which of these tend to be chronic? Okay, so first we'll start off with the acute hepatitis. When it comes to hepatitis B, does that tend to be acute or chronic? Okay. Hepatitis B can be chronic, but it tends to be more acute than chronic. The breakdown is about 80% of the time it's acute and 20% of the time it's chronic. Okay, that's hepatitis B. What about hepatitis C? Acute or chronic? You're 50-50. Chronic, good. And so the breakdown goes the other way for hepatitis C. About 20% of the time it's acute, and 80% of the time it goes chronic. And so in terms of, really wanting to develop a drug to treat a certain type of hepatitis, C is the one that has really been stressed in terms of getting a good treatment, because it tends to go chronic. Chronic hepatitis leads to cancer, and so that's one we worry about. Okay, and then hepatitis A, hepatitis E, these are both our fecal oral, so these are definitely going to be acute. And then hepatitis D always goes along with hepatitis B. You cannot have hepatitis D without hepatitis B. The reason is because hepatitis D doesn't have its own lining. It doesn't have its own membrane. The actual virus itself doesn't have its own membrane. It needs hepatitis B's membrane to be able to go on living, okay? And so you will never see hepatitis D by itself. You will always see it with hepatitis B, okay? Great, so whatever hepatitis B does, that's what D is gonna do. Great, so let's go to the text here. For hepatitis A and E, we said fecal oral transmission, great. HAV is commonly acquired by travelers. E, we think about contaminated water, undercooked seafood. If you have a patient that comes, say, from India and is presenting, with this malaise, nausea, vomiting, low fever, and then pain in the right upper quadrant, you're going to think about hepatitis. They just traveled. You're going to think about hepatitis A. Okay. And so, we always have to talk about antibodies. For hepatitis A and E, you can look for IgM for that active infection, and then IgG is protective. So if someone has Hep A, IgG in their blood, they cannot get hepatitis A again. And that makes sense to us, right? That's the way the immune system works. If you have an IgG for something, it should protect you. When we talk about hepatitis C, we're going to find out that's not really the case for all viruses, but in general, if you have the IgG, it's protective. You can't get it again. Okay? And hepatitis E, the one thing that you really need to know about for hepatitis E is that we worry in pregnant women that your patients can get a complete liver necrosis. In pregnant women only, we worry about a complete liver necrosis. Okay? So whenever you think about pregnancy, hepatitis, and virus, think about this hepatitis E, because there is that connection there. Okay. Hepatitis B, parenteral transmission, childbirth, unprotected intercourse. IV drug use, yes, but less so than hepatitis C. When it comes to IV drug use, that's a needle. When it comes to needles, think about Hep C. Okay. Although it is listed here under Hep B, it's possible to transmit it that way. However, the major association with IV drug use I want you to have is with Hep C. Okay. So, in terms of what it causes, acute hepatitis 80% of the time, chronic disease in 20% of the time. Okay, and so let's talk about the markers for hepatitis B before we move forward. So HBV serum markers. Okay, before I show you this slide, I'm just going to, kind of write down a couple of the names of our serum markers. Okay, so the first one we can talk about, whenever you talk about these serum markers, they will all start with HB for hepatitis B, and then it will follow with another letter. Okay, well, that letter may be S, that letter may be C, that letter may be E. They all denote something else. HBS is for surface antigen or antibody. HBC is for surface core antigen or antibody, and E is for envelope antigen or antibody. Okay, so we put HB, we write S, C, or E, and then after that, we're going to write whether it's an antigen, meaning part of the virus itself, or antibody, meaning part of the body's defense against the virus. Okay, so after these three letters, we're either going to write AG, meaning antigen, or AB, meaning antibody to whatever we've written just before that. Okay, and I'm sure you're very comfortable with this. I'm just going through it just for a fun little review. So each of these combinations, right? We can have HBS AB, HBC AG, and HB EAB, right? We can have so many different combinations of these things, and they all mean something different, okay? But they're not all equally important. And so we're going to start off with our HB surface antigen. Our HB surface antigen is part of the surface of the virus, right? Go figure. They name it surface for the surface. That's great. The surface antigen, if you ever see surface antigen, that means that your patient has hepatitis B, no question. If you see surface antigen, that's hepatitis B, no question. I don't care, acute, chronic, they've had it, for 200 years and somehow they're still alive. They have hepatitis B because you see the antigen, okay? Now, if you have HBs antibody, that can mean one of two things, right? What are the two things that can mean? Yes, they are immune. That is universal. If you see antibody, they are immune to hepatitis B, right? However, you don't know whether they're immune because they were infected before or they're immune because they had the vaccine, right? Good. So if you want to know that, you need to look at one of these other types of antibodies, okay? And so the antibody that will tell you whether or not they've had the vaccine or whether they had an infection is your HB core antibody. Okay, so we do our test on our patient and we see they have HB surface antibody. We want to know whether that means they had the vaccine or they had the virus in the past. So we check for HB core antibody and we see it's positive. Great. So does that mean they had the vaccine or that they were infected before? If they're positive for core antibody. Yes, they're positive for core antibody. Yes, very good. So if you see surface antibody and core antibody, they had hepatitis B, they recovered, they're good now, they're totally protected, and you know that they had it in the past. Okay? If you see surface antibody and no core antibody, there's no reason to freak out. They're still protected. They still will never get hepatitis B, but you know that they had the vaccine in the past. Okay? And so that's sort of the big thing that they will ask questions about there. Okay? And so those are some of the major things we need to know about surface and core. However, I haven't talked about HBE. There's really only one case where you need to worry about the envelope, and the one case is for envelope antigen. Not antibody, but antigen. If you see a high level of envelope antigen, it means your patient is very infectious. Okay? This tells you about infectivity. Okay? I'm not going to write infectivity because it's going to take 10 years, but I'll write infect. So if they have HBE antigen at a high level in their blood, it tells you they're very infectious. Any sort of contact with their bodily fluids may result in a infection, right? Because you can have, just because you have your bodily fluids interact with a person's bodily fluids with HBV, that's not guaranteed 100% you're going to get HBV, right? There's a chance that you may be infected with HBV. The level of envelope antigen in that patient's bloodstream will dictate how high that chance is. Okay, does that make sense? Okay, good. And so let's go to the slide and sort of look at these serum markers, and we can sort of add a little bit more information looking at this diagram here. And so our surface antigen, this is going to peak during our active infection, and patient is going to be symptomatic. If you see surface antigen, your patient is infected. Again, we said, I don't care if it's acute, I don't care if it's chronic, I don't care if your patient has had it for 200 years. Seeing surface antigen means they have hepatitis B. Okay? Envelope antigen, again, this signifies the infectivity because the virus is actively replicating. Seeing your anti-core antibody, this is really helpful. Your core antibody is seen during the window period. What is window period? So we said that surface antigen is going to rise. And then as your body is mounting a defense, it's building up its HBs antibody, right? It's building up the antibody in the bloodstream. It's trying to attack the virus. So the levels of HBs antibody are starting to rise. As those levels rise, the levels of surface antigen fall, they fall to zero. Okay, so our surface antigen is now at 0. However, there's a small period where you won't see anything, and then after that, your surface antibody will start to rise. Okay? And that tells you that you're protected. So what's happening here is our window period. What's happening during this time is all of our surface antigens, if this is a surface antigen, all the surface antigen is bound to the surface antibody. Okay? They're stuck together like this. And so if we test for one, it's going to look like it's not there. If we test for the other, it's going to look like it's not there because they're all bound together. And so when you do this test during the window period, it looks like you're going to have a negative surface antibody and you're going to have a negative surface antigen because they're stuck together. If you test for either, they're both going to be negative. Okay? And so that's why the core antibody is helpful because it will be positive during this time. Okay? Good. And so we have some questions here about the window period. Great. Time between the disappearance of surface antigen and the appearance of surface antibodies. Okay, and if you look on this diagram here, you see on the x-axis we have time, on the y-axis we have levels of all of the different antigens and antibodies. And so for the window period, what I'd like you to look at is, here's our surface antigen. Okay, this is when it's present in our bloodstream. Here's our surface antibody. This is when it's present in our bloodstream. And so from the end of this line all the way through to this line, whether we test for antigen or we test for antibody, they're both going to be negative. However, if we test for this core, it will be positive. And so that's helpful during the window period. Okay? And that is something that they will ask about from time to time. And so I wanted to make sure that that was clear. Any questions on that window period? No? Okay, great. So moving on from Hep B then, we can move to Hep C. We said needle sticks is the major way, although you can get it through unprotected intercourse. You're going to get acute hepatitis. That is going to turn into chronic, okay, in most cases. Again, remember the 80-20 rule. 80% of the time Hep B is acute. 80% of the time Hep C is chronic, okay? Now, when you have a patient with Hep C, they've had Hep C for a year now. They don't really have too many symptoms. So you test for Hep C virus IgG. Okay, you're going to test for Hep C virus IgG. It comes back positive. Great. That means this patient is protected from Hep C, right? If they have Hep C IgG, they're protected, right? They're not protected. This is the trick that they are going to get you with on the exam. IgGs against Hep C virus are not protective. And the reason is Hep C has this very tricky way of changing its structure. The way that it looks, the proteins that are on the outside of it will change over time. And so, you get hepatitis C, you get this inflammation of your liver, your body reacts by building up all these antibodies, it fights off the hepatitis C, and you're like, okay, my patient's good. But what's really happening is Hep C has now changed what it looks like. It's going to start an infection in the liver again, and your body's going to have to start a new immune response to the Hep C. As soon as it finishes that immune response, Hep C is going to change again and change again and change again. Okay? And so always remember that IgGs against Hep C virus are not protective. Not protective because Hep C can change what it looks like and then hide from the immune system and start another infection as well. Okay? Great. And what else do I want to say about Hep C? Nothing else, I don't think. Do you have any questions there about Hep C? No? Okay, great. So then let's move forward. We talked about cirrhosis, which is really our end-stage liver. We have those bands of fibrosis we talked about before. Look for portal hypertension. This is going to give us our varices. And then so just for fun, where do we get varices in portal hypertension? Good. Yes, excelente. So this portal hypertension is leading to esophageal, rectal, and umbilical varices. And so those are the places that you may see some increase in the size of the veins. And you see that here, esophageal varices, hemorrhoids, and caput medusae. This is our umbilical varices. We talked about how if this is our umbilicus, the varices the veins kind of go out from the umbilicus in this way, kind of looking like snakes, kind of bringing up those images of Medusa from Greek mythology. She had all those snakes for her hair. If you look at her, you turn to stone. So that's sort of the fun way that they gave us to remember that. Other things you can see in cirrhosis, mental status changes, asterixis, which is shaking, tremors of the hands and extremities, coma due to the ammonia levels. You can see some gynecomastia, spider angiomata, and polar erythema. These are all due to increase of estrogen. And so the liver is important for breaking down extra estrogen. If you have too much estrogen, these are the three things that are going to happen. You're going to have enlargement of the breasts, spider angiomata, which are some blood vessels that look like spiders in the skin, and palmar erythema. The palms are going to turn bright red. And that's all due to estrogen. That's what estrogen does for whatever reason. Okay, and of course jaundice, which we talked about before. Some more advanced things that I really want you to keep in mind. The liver synthesizes proteins for our body. So losing those proteins means you're losing albumin, which means you're losing that oncotic pressure in our bloodstream. Proteins provide a force that keeps fluid in our bloodstream. If you lose those proteins, fluid is going to start leaving our bloodstream and going into interstitial spaces. And so seeing pitting edema in the legs is a typical case. Seeing ascites is another case that you would want to be worried about. Okay? Great. Liver also synthesizes our clotting factors. And so your patients may present with increased bleeding, from their gums or from any other place because they lost their clotting factors. Okay? Great. So cirrhosis has a lot of different, problems with it, with the presentation, and so be comfortable with that. For each of these things, this is from your first aid book. For each of one of these things, you should be able to draw a little line and write why your patient has that. And I don't mean you put a line here and you write cirrhosis, right? Okay, that's cheating. That's the easy one. What I want you to write there is that the ammonia is building up and causing encephalopathy, right? For anorexia, I want you to write that cirrhosis. Yes, correct. Very good. No, for anorexia, I want you to write that there's fluid and edema in the wall of the stomach that causes your patient to have a constantly full feeling in their stomach and lack of appetite. Let's see what else. Thrombocytopenia. Why do we have low platelets? Why do we have anemia? Why do we have bleeding disorders? Each of these things, the problem is cirrhosis, yes, but what about cirrhosis? Why do we have palmar erythema? All of these things you should be able to sort of explain, and that's really going to help you on the exam. Okay, great. All right, and then so here's sort of a diagram showing how we ultimately get ascites. I think this is a little bit complicated. I really don't even want to go through this. I think it's going to take a long time, and it's pretty straightforward. In ascites, you have decreased albumin. This is the biggest problem. Decreased albumin, and then that decreases the pressure to keep fluid in the bloodstream. Fluid's going to go everywhere, including into the abdomen, giving you ascites. Okay. You can also think about increased plasma renin activity, increased aldosterone, increased sodium, and increased nitrogen, et cetera, et cetera. Okay. You can kind of look through this and see if there's anything that doesn't make sense. Ask me next time we meet, and I'll go through it with you. Okay. Okay. Great. So last is our biliary system. Two big problems with our biliary system that I want you to know and not get confused about. Primary biliary cirrhosis. primary sclerosing cholangitis. The reason that these two have names that are very similar is because a lot of these doctors hate medical students and they want us to be sad. But we're not going to be sad because we're not going to get them confused. So primary biliary cirrhosis, here we have an autoimmune condition where we have destruction of bile ducts, right? So here's our liver, here's our gallbladder, giving us our cystic duct, and here's our hepatic ducts. Here's our right hepatic duct, here's our left hepatic duct. They both join together, and then those join with the cystic duct to give us our common bile duct, and that is going to go into the ampulla, right? And so we said that we have autoimmune destruction of intrahepatic bile ducts. So the bile ducts that are in the liver. I'm talking about this one, and I'm talking about this one. Okay, that is where the destruction is. If you're asked to label it on a diagram for primary biliary cirrhosis, it's intrahepatic, inside the liver. Okay, this associate with women. Average age is going to be 40 years. It's autoimmune. Autoimmune you always associate with women, right? That just happens to be the case. Not trying to be, misogynistic or anything here. This is just medicine. Autoimmune conditions are associated. Women tend to get them more than men, unfortunately. We're not really sure why it happens. What we can see in terms of testing is anti-mitochondrial antibody. I'm putting a star here. Anti-mitochondrial antibody is seen in primary biliary cirrhosis. You're going to see features of obstructive jaundice, and so eventually it's going to lead to cirrhosis. That's something that these two conditions have in common. They both kind of progress to cirrhosis. Okay. Next is our primary sclerosing cholangitis. First, this is associated with one of the inflammatory bowel diseases, right? Crohn's or ulcerative colitis. Which one is it associated with? Excellent. Yes, UC. It is strongly associated with UC. Most patients with primary sclerosing cholangitis have ulcerative colitis. So very good. Inflammation and fibrosis of intrahepatic and extrahepatic. So I'm talking about this one, I'm talking about this one, and I'm talking about all of these. Okay. Any bile duct that is essentially in the body can be affected here and can start breaking down. Buzzwords you need to know. Onion skin appearance when you put dye into the bile duct. So typically what we will do is we will put a little catheter at the ampulla and we shoot dye up through the common bile duct, shoot dye up into the gallbladder, shoot dye up into the liver, and then we take an x-ray and see what it looks like. And what you typically see when you do that is this beaded appearance where, because you're having sclerosis of your bile ducts, you will have areas that are very dilated and areas that are very narrow. Area that's dilated, area that's narrow, area that's dilated and narrow, kind of giving you this beads on a string appearance. And what's happening is these narrow parts is where the problem is. These narrow parts are sclerosing, they're becoming very narrow, and they're not allowing bile to flow through. And these dilated parts are actually the normal parts of your biliary system, where you're just having backup of bile at those points, essentially. Okay, so onion skinning and beaded appearance are the buzzwords I want you to associate with primary sclerosing cholangitis. Okay. In terms of laboratory testing, look for that P-ANCA. Patients present with obstructive jaundice. Again, cirrhosis is the ultimate thing that happens in these patients, unfortunately, and they do have a risk of cancer of the biliary tract. Okay, and so these, man, I cannot tell you, you really want to have a nice, comfortable feeling about these. It's going to take flashcards, Natalia. It's going to take practice doing them over and over again, but be comfortable with these terms. Onion skinning, beading, and which those are associated with. One of the things that always helped me remember that primary biliary cirrhosis is associated with anti-mitochondrial antibody is I would always say MyB, right? So MI for mitochondrial and then B for biliary cirrhosis. And that gives you sort of that anti-mitochondrial antibody and then the B for primary biliary cirrhosis. I don't know. I told you my things of remembering are stupid, but they work for me. So I'd always say MyB, and that is a mitochondrial antibody with primary biliary cirrhosis. And whenever I think of anti-mitochondrial antibody, that makes me think autoimmune. So now I'm thinking autoimmune is more common in women. So I'm thinking of more of a 40-year-old woman Versus, and now that I know everything about primary biliary cirrhosis from just that one thing, I know everything else has to be primary sclerosing cholangitis, right? Just know one really well, and then you can just say everything else is the other one, right? And so that was my sort of cheating way of getting through this particular topic because it can get tricky. Okay, any questions here? Do you have any questions here on this one? No? Okay, good. Anything I can ask you? No, I think you're doing good today. I'm going to leave you alone. So, hepatocellular carcinoma, last big thing that we need to talk about is cancer of the liver. It's the most common malignant tumor of the liver. As you know, most tumors of the liver are metastasis from somewhere else. So this is the most common primary tumor. Associated with HBV, HCV, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, hemochromatosis, alpha-1 antitrypsin, aspergillus aflatoxin. You do need to know these being associated with hepatocellular carcinoma. So I'm putting 2 stars here. 1 for all of these other random things, autoimmune disease, hemochromatosis, and alpha-1 antitrypsin, and the aflatoxin. They really want you to know this. I think I had a question on aflatoxin on my step 1, so definitely know that one. Associated with activation of beta-catenin and inactivation of P53. I don't want to spend a lot of time talking about this because I kind of want to move on to our endocrine talk, but I don't like just skipping over things. So beta-catenin, this is a protein that connects cells to other cells. And so if this is our hepatocyte, we should have another hepatocyte next to it, right? And so beta-catenin is the protein that connects these cells to one another. Okay? And so if there's a hepatocyte, say there's no hepatocyte over here, this beta-catenin will not be connecting to anything, and so this beta-catenin will sort of die off and disappear. Okay? And so that's the normal functioning. If you have an activation of beta-catenin, what ends up happening is the beta-catenin will appear here even though there's no hepatocyte on this side. And so this will trigger a sequence inside of this hepatocyte to say, you need to start mitosis and increase your number. Okay? And so we're going to end up with mitosis and getting a large number of hepatocytes when we don't want them. Okay? And so that's the role of beta-catenin. Great. Budd-Chiari syndrome is essentially a portal hypertension due to cirrhosis. Well, okay, so that's not exactly it. It's thrombosis of the hepatic or the portal vein. Okay, is Budd-Chiari syndrome, and that's something that you can see here. Findings here: jaundice, a tender liver. When you're pressing on the liver, it doesn't feel great. Anorexia. It spreads through the blood, and diagnosis: alpha-fetoprotein. Alpha-fetoprotein, the same thing that we said, something that you check for in, a pregnant mother's blood supply, you're going to check for in liver cancer. Seeing it over 400 is a pretty strong indication that your patient has this cancer. Okay. Any questions? No? Okay. Questions. So I have questions for you. If you want to read through this one, Natalia, and let me know what you think, we can talk through it together as well. Okay. Mm-hmm. Oh, nice. Yes. Yes, it is C. Very good. So, Please tell me, how did you arrive to C? Mm-hmm. Good. Yeah, that's true. That's true. Mm-hmm. 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 Good. Good. Excellent. Great. And so, very good. So, talk to me about Gardner's syndrome. What is Gardner's syndrome? You're absolutely right. You got the question right. I'm just going to torture you for a little bit longer. So, Gardner's syndrome, what is this associated with? Obviously, it has something to do with polyps, right? Mm-hmm. Good. Good. Excellent. Yes. So, Gardner's syndrome is going to be FAP plus osteomas, right? Which is tumors of the bone, which you said. And you can also see, what is it called? The fibromas or something like that, right? Some kind of fibrous connective tissue tumors. Okay, some kind of fibroma. I don't remember the exact term. I don't think it's fibroma, something like that. Okay, and so great. So what is FAP? How is FAP different from what this patient has? Yes, there's no osteoma, so you're right. It's definitely not Gardner syndrome. But what about, just to get kind of really dig into the details here, why I'm saying it's not FAP. Why am I saying it's not FAP? No, 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 don't doubt it. You made the right choice here, and you're right. It does have to do with the polyps. And so in FAP, you see hundreds to thousands of polyps. Hundreds to thousands. This patient had multiple, yes. Multiple to me typically means like 10, 15, maybe even 50. In FAP, the minimum is going to be 100. Okay, and so if this patient had 100 polyps, they would have made that more clear in the question stem, right? They would have said, they would have used different words rather than just the word multiple. Multiple to me means some number, but under 100 for sure. Okay, versus FAP where we see hundreds to thousands of polyps. That's a lot of polyps. Okay, great. So that's Gardner syndrome. What about Turco syndrome? Good. Yes, Turco turban. And so this, rather than being Lynch, this is going to be our FAP again. Okay. So just remember, Lynch syndrome is our HNPCC, meaning hereditary non-polyposis. In Lynch syndrome, we do not have polyps. Okay. There we really see more like sessile type tumors and adenomas and things like that. Okay. FAP, hundreds to thousands of tumors. Lynch syndrome is just going to be some other types of things. Okay. So great. But yes, you're absolutely right. FAP plus brain tumors. Okay. Great. And Putz-Jaeger's, we didn't talk about, so I'm not going to make you answer me there. Putz-Jaeger's, essentially you see hamartomatous polyps, meaning bloody type growths, anywhere in the GI tract. And typically the first place this is going to manifest, I'm going to try and draw it and see if you can notice what I'm drawing. Probably not. The first place that you notice these dark spots is going to be on the lips. Okay, so this is actually supposed to be lips. This is a nose. These are eyes. Okay, so this is the patient's has very luscious lips. And you can see a lot of dark spots on the lips, almost looking like freckles, a lot of like dark purplish freckles on the lips. Think about Putz-Jaeger's syndrome. And so you can imagine all through their GI tract, they have these bloody little growths throughout their GI tract. Okay, as well as some polyps in their colon. Cronkite Candida syndrome. This is not step 1 material. This is not even step 2 material. This is a super, super rare disease where you get colon polyps, but you also get things like alopecia. But I'm not even going to fill your head with that nonsense because it's not something that you need to know for testing right now. If you go into becoming a gastroenterologist one day, you can learn it then. Which, by the way, I don't think I've ever asked you, what are you interested in doing after medical school? Dermatology? Yeah, nice. Good choice. Yeah. Yeah, that's a good choice. Put some steroids on it and come see me in a week, right? Yeah. Yeah. Great. Good choice. Okay, good. So if you can read through this one and let me know what you think. Okay. 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 Mm-hmm. That's your guess? Good. That's the right answer. So what is Borje's syndrome? Besides just repeating this whole question stem. Is the problem in the esophagus, in the stomach, in the small intestine? Where is the problem? You can be happy once you've passed step 1. Okay. Okay, so let's just look at this question step and see if we can figure it out. So, this patient was vomiting. Sudden onset, retrosternal chest pain, strange popping sensations. Those are sort of the 3 things he's complaining of. And so when it comes to vomiting and your patient coming in with severe problems, there's 2 problems, right? It's either Mallory-Weiss or Borje's syndrome. Okay, so Mallory-Weiss, we said, we think of Mallory-Weiss as a patient that's maybe drinking a little bit too much one night and then vomits some and then starts vomiting up a little bit of blood. Okay, this is not a chronic alcoholic, but really somebody that just kind of went a little too hard, started vomiting, and a little bit of blood came up. Okay, and Mallory-Weiss is due to a tiny little tear. This is our esophagus. That's the mucosa. This is the wall. And so Mallory-Weiss is due to a little tear in the mucosa of the esophagus. Okay, and then so a little bit of blood comes out, and your patient sees blood in their vomit, and then they come in. Okay, and so we said that really we just treat that symptomatically, give them a little pain reliever, and send them home. They will be okay. For Borje's syndrome, rather than just having a little tear in the mucosa, we have a complete tear of the wall. Okay, and so the esophagus is in our chest, right? No groundbreaking information there. Because of that, air is going to be able to get from our esophagus and escape into our chest cavity, meaning it's going to be going all around the heart. It's going to be going all around the lungs. It can even lead to pneumothorax. We have air where it's not supposed to be. And so when you hear this popping sensation under the fingers, when you push on the skin of the upper chest, this is something very scary. It's called crepitus. And this means that his esophagus is basically blown wide open. There's a hole in the wall of the esophagus. This is very, very severe. This patient needs to be brought to surgery. Typically, these patients are going to have a low blood pressure, very, very sick patients. Okay? And so that's our Borje versus Mallory-Weiss. Excellent. Okay. So let's see. What is this one? Okay, great. You already know that. So how about this question? And then we'll move on to endocrine. Okay. Good. Excellent. Yes. No, not really. Not really. No. Good. Excellent. Ulcerative colitis. And I absolutely agree with your reasoning. Seeing that, especially when they say the lesion is in the distal colon, they're begging you to pick ulcerative colitis at this point. Okay. And so you're obviously going to pick that when it comes to test time. So great. I think that these questions are too easy for you. I think I need to give you more difficult questions. No? You're good. Okay, so my last question for you, and then I promise we'll go to endocrine. Irritable bowel syndrome. You said that these symptoms are not like the symptoms in irritable bowel syndrome, which I was happy to hear. I agree with you 100%. What are some of the symptoms of irritable bowel syndrome? How are you going to know that it's irritable bowel and not like celiac disease or something like that? Just in general, what are the symptoms of irritable bowel syndrome? Mm-hmm. Yep. Yeah. Mm-hmm. Yeah. Definitely. Excuse me. And so the big thing here, everything you said is correct. The big thing here is that irritable bowel syndrome is something considered a diagnosis of exclusion, right? So you have to literally test for everything before you can give that diagnosis. So you can never just jump and say, oh, this is irritable bowel. No, no, no. You need to really make sure everything else has been ruled out. However, if they give you a certain phrase, that should definitely push you a little bit in the direction of irritable bowel, although I still want you to rule everything out. If they say that they have abdominal discomfort relieved by defecation, meaning they have abdominal pain, not pain, but discomfort that's relieved by pooping, that is sort of like the buzzword phrase that is associated with irritable bowel syndrome. Okay, so abdominal discomfort relieved by defecation tends to be, they're usually talking about irritable bowel when they say something like that. Okay, but I still want you to consider all the other options first. It's still going to be low on your list. It just moves up a little bit. Okay, great, excellent. And so that wraps us up for GI. And what fun it was doing GI. There are more questions on here. If you have time, you can go through these questions. Some of them are kind of fun, and we can talk about them together if you'd like. Do you want to do that? Do you want to do the rest of these questions, and then we'll just go through them quick at the start of the next session? Yeah, exactly. I think that'll be good. So yeah, if you want to go through these questions on your own time, that's fine. Otherwise, we'll go through them together next time at the start of the session. Just quickly, we'll just quickly go through the questions and then continue. Okay. Excellent. Great. All right. Let me just bring up my endocrine lecture and we'll get started here. Okay. Full screen. Okay, can you see my screen, Natalia? Okay, great. So let's get started here with endocrine. And we're going to start off with a question to kind of Get us in the mood to do some endocrine. So you've been asked to deliver a lecture to medical students about the effects of various body hormones and neurotransmitters on the metabolism of glucose. Oh my God, that's that they're talking about me. Which of the following statements best describes the sympathetic stimulation on glucose metabolism best? A. Norepinephrine causes increased glucose absorption within the intestines. B. Without epinephrine, insulin cannot act on the liver. C. Sympathetic stimulation to the pancreas increases insulin release. D. Peripheral tissues require epinephrine to take up glucose. And E. Epinephrine increases liver glycogenolysis. Okay? And so here we're talking about, sugar, blood sugar, how to raise it, how to decrease it. And so the reason that we start off with this is I really want to give you this concept of your fight and flight system. We're going to add, from fight and flight, we're also going to add increased glucose. Okay? And for our rest and digest, we're going to add to that build up muscle, store glucose. Okay? So fight and flight system is fight, flight, increase blood glucose. Rest and digest system is rest, digest, store glucose, build muscle, etc., etc. Okay? Store fat. It's basically our building time. Okay? Versus our fight and flight is our breakdown time. Okay? So now we can kind of get into the sympathetic stimulation. Sympathetic is, of course, our fight and flight. So norepinephrine causes increased glucose absorption within the intestines. Okay, so here, this technically, if we think about it, increased glucose absorption would increase blood glucose. We said that norepinephrine is part of the sympathetic system. Sympathetic system, its goal is to raise blood glucose. Increasing glucose absorption would raise the blood glucose. I absolutely agree with that. My only problem is during our fight and flight, during sympathetic activation, do we have a lot of blood flow to the intestines? Not really, right? Our blood flow during fight or flight is really going to our muscles, going to our brain, going to our heart. We're trying to run away from a bear. So during fight or flight, there's not a lot of blood going to our intestines. Blood really goes to our intestines during rest and digest time. And so, while we're talking about sympathetic stimulation, yes, it's true that increasing glucose absorption would increase blood glucose. I don't agree that norepinephrine is active at the intestines, and so I'm gonna put a pin in this one. Maybe that's the answer, maybe not. Without epinephrine, insulin cannot act on the liver. Okay, so epinephrine, this is part of our sympathetic system. This is part of our system that raises the blood glucose. What about insulin? What does insulin do to blood glucose? Does it increase blood glucose or decrease blood glucose? Decrease, exactly. And so epinephrine should not be doing something that decreases blood glucose, right? And so we can take this out. Beautiful. Sympathetic stimulation to the pancreas increases insulin release. Okay. So what do you think about this one? So sympathetic's goal is to increase blood glucose. During fight and flight, we want to have a lot of sugar available to use for running away from that bear. However, exactly, increasing insulin is going to drop our blood glucose. So let's take this out. Excellent. Peripheral tissues require epinephrine to take up glucose. So this, is an interesting thing, but I think we know enough about diabetes and the endocrine system without even doing a lecture to know that epinephrine is not the hormone that causes cells to take up glucose. No. Insulin is the hormone that causes cells to take up glucose. So we know this is wrong as well. Okay. Epinephrine increases liver glycogenolysis. Okay. And so epinephrine, part of our sympathetic system, the liver glycogenolysis. If we are lysing glycogen, that means we are breaking down glycogen. Breaking down glycogen means more free blood sugar, right? And so this one I really like a lot. I think we'll go with this one. Sympathetic system, think about increasing your blood sugar. Think about liver glycogenolysis, really getting more energy available. That's the whole point of the sympathetic system, endocrine-wise. And so that would be our answer there. Okay, great. So this is what I would consider a more difficult type question. The question bank that I got this question from, it's tricky, right? All the questions from the question bank I got this question from are like this. They're just weird, right? You read the options and you're like, what the heck are you talking about? But you know that the step one is going to have questions like that are very tricky, right? So we're gonna do more and more questions like this. Okay, great. So let's get into the endocrine system in general. So as an overview, endocrine system acts with the nervous system to coordinate activity of body cells. The nervous system is great from you want to get a signal from point A to point B. The nervous system is great for that. However, it's not very efficient if you want to get a signal to all of the cells of the body, right? Say I want to talk to every single fat cell in the body. It's going to be hard to do that via nerves. There's a lot of fat cells, especially for me. So the nervous system wouldn't work. You need something that's going to go through the bloodstream and directly bind to those fat cells. So the endocrine system is great for that. Hormones are great for that. Influences metabolic activities by means of hormones transported in the blood. It is more slow than the nervous system, but they also last longer than the nervous system. Okay, so slower but last longer. And endocrinology in general is a study of hormones and endocrine organs. Okay, so many systems are involved under the umbrella of endocrine: reproduction, growth and development, maintenance of electrolytes, right? Thinking about our aldosterone, renin, antidiuretic hormone, just to name a few different hormones that act on the on the kidneys to manage electrolyte levels. Parathyroid hormone, vitamin D, all of these things are hormones that are going to maintain the regular balance of electrolytes in our blood. Cellular metabolism, energy balance, I'm talking about thyroid when we talk about metabolism and energy, and mobilization of the body's defenses. So, thinking about activity of the immune system being sort of modulated by activity of cortisol is something you can consider there. So just sort of a overview of all of the different glands that we're going to talk about, from the hypothalamus, pituitaries, thyroids, parathyroids, the thymus we're not going to talk about, adrenal glands, pancreas, ovary, and testes. Great. But there are other cells that produce hormones. So adipose cells, fat cells in our body, produce estrogen. Fat cells in our body produce estrogen, believe it or not. And so when you start to think about, these patients with polycystic ovarian syndrome, this is something that's really becoming more and more common. I'm sure you've seen it in your clinical rotations. These patients tend to be a little bit more overweight. They have more adipose cells. Those adipose cells are producing estrogen. Those levels of estrogen are going to mess with or interfere with the levels of estrogen being produced by the ovaries. And so that can lead to problems, for the ovaries trying to, know how much hormone to produce. The ovaries end up developing cysts on them. Okay, so that's my very non-scientific way of describing polycystic ovarian syndrome. But also I want to kind of make a connection for you why, it's important that adipose cells make estrogen, because there's, there can be some problems there. Cells of the small intestine, stomach, kidneys, heart, these are all going to be making hormones, okay? So small intestine, we talk about, and the stomach, we talk about gastrin, we talk about CCK being, these are more locally available hormones, but hormones nonetheless. Kidneys produce renin, they produce EPO. EPO is a hormone that will go to the bone marrow and tell the bone marrow to make more red blood cells, and that's made by the kidneys. Okay, the heart is going to make something called a brain natriuretic peptide, BNP. BNP. And BNP is synthesized when the heart gets too stretched out. It causes us to diurese or to decrease the amount of fluid that we have in our system. And so just sort of an overview about how a lot of these organs, we don't really think of them as endocrine organs, but they do synthesize hormones. Okay, great. So long distance chemical signals are hormones. Autocrine hormones are chemicals that work on the same cells that secrete them. Paracrine are the ones that work locally. So when you think about the small intestine synthesizing CCK, and that CCK kind of goes nearby to the gallbladder and causes contraction of the gallbladder, that's paracrine. It's working on something very nearby. When you think about those antral cells of the stomach creating gastrin, that gastrin goes nearby to the body of the stomach and stimulates those parietal cells to create acid. That's paracrine. It's nearby. And so that's what we call paracrine hormones. Okay. In general, hormones can work in a number of different ways. So they can change the permeability of plasma membranes by changing ion channels. Stimulating synthesis of proteins is going to be the major way of hormones working. Activate enzyme synthesis, induce secretory activity, stimulate mitosis. It can lead to hyperplasia of certain cells. So they have a lot of different mechanisms. In general, we have amino acid-based hormones. These are peptides. These are long series of proteins. Okay, it's just a bunch of little amino acids, basically. And these amino acids, when they bind to a receptor that has a similar shape to that, when they bind to that receptor, the receptor is going to change shape, have a change of shape, and then cause a signal downstream in the cell. Okay, that's a peptide hormone. It binds at the surface of the cell. Other types of hormones do not bind at the surface. Other types of hormones, if this is our cell wall, here's our nucleus. Excuse me. Here's our steroid hormone. Steroid hormones contain cholesterol. That means they can go straight through the membrane of our cell, get into the cytosol, pass through the cytosol, go right to the nucleus, and ultimately bind directly to our DNA and cause changes to our DNA. That's pretty cool. They don't need any cascade. They don't need any G protein coupled receptor. They don't need any of that. They just straight up, they go into our cells, they go into the nucleus, and they say, hey, make this change right now. I'm going to help you do it. And so that's the way that steroid hormones work. Okay. It's very important for step one to know which of your hormones are amino acid type that are binding at the surface, and which type of hormones are going to be diffusing into your cells and causing a change at the level of the nucleus. Okay. And so in general, for me, it was easier to memorize all of those that go straight into the cell and bind at the nucleus. So all of my steroid hormones. What are my steroid hormones? Cortisol, aldosterone, androgens, testosterone, estrogen. So those are all the sort of steroids that, are the first ones that come to your mind when you think of steroids. And then the other one that's not really a steroid but works in the same way is thyroid hormone, T3 and T4. The way it works is the same thing. It will be outside of the cell. It just freely diffuses into the cell, freely goes to the nucleus, and then starts to make changes there. Okay? Okay, great. And so here are water-soluble hormones, which are our amino acid-based hormones. They have to work through second messengers. And so they will bind to a receptor that triggers an activation of a G protein. That G protein will go on to cause a cascade and cause changes inside of the cell itself. Okay. And so there's three types of G proteins. We have G sub S, G sub I, and G sub Q. G sub S ultimately is going to cause an increase in the level of CAMP in our cell. That's the goal of G sub S. When you activate this G sub S G protein, you have an increase of CAMP. CAMP is a second messenger that will go on and cause changes in our nucleus that change, the transcription of certain genes, that cause more proteins to be expressed and things of that nature. Okay? So that's increased CAMP. G sub I causes exactly the opposite. These two are the easy to remember because this just causes the opposite. This is going to decrease the level of CAMP. Okay, and so in general, this is going to decrease the levels of activity if you bind the G sub I receptor. Last is G sub Q. G sub Q increases levels of IP3 as well as calcium. And ultimately, the goal of G sub Q is to increase levels of calcium. What you're going to notice about G sub Q receptors is they tend to be on cells that have the ability to contract. They tend to be on things like smooth muscle cells. Okay, if you think about the smooth muscle on the wall of your arteries, those all have G sub Q receptors where an increase of calcium, because it's a muscle, will cause a contraction. Okay, and so that's sort of like a high yield tip for you in general. When you're looking for G sub Q receptors, think about muscles, like smooth muscle tends to have G sub Q because G sub Q works by increasing calcium, and muscles love calcium. That's how they work. Steroids, however, do not need that cascade. Steroids, like we said, these are able to diffuse directly into the cytoplasm, in the cytoplasm or in the nucleus. It sort of depends. But at some point, it's going to bind a receptor. And then that receptor is going to help that steroid to bind onto the DNA and cause transcription of an mRNA. That mRNA will go outside of the nucleus. Ribosomes are going to bind onto it. And ultimately, we will have increased production of certain proteins or enzymes. Okay? And so this statement here is incredibly important. You will be asked about this, I guarantee it. Steroid hormone is able to diffuse through the plasma membrane and directly activate genes. Directly activate genes. Okay, there's no second messengers. There's no cascade that happens. It just binds its receptor inside of the cell and then directly goes to the DNA and starts making some changes. Okay? Great. And so this sort of shows our CAMP system. Again, a hormone binding a G sub SG protein. We have a GTP molecule that activates the G protein. That G protein ultimately will bind to adenylate cyclase, which will elevate your level of CAMP. This is an enzyme, right? This enzyme makes CAMP. CAMP will activate a protein kinase, which ultimately will trigger responses. So activates enzymes, stimulates secretion, opens ion channels, etc., etc., etc. So what types of hormones work via CAMP? So epinephrine is a classic one. So our beta receptors work through CAMP. And so a lot of our hormones. So ACTH, FSH, luteinizing hormone, glucagon, PTH, TSH, and calcitonin. Okay, and so the mnemonic for this one is flat pig, FLAT pig. Okay, and so F for FSH, L for LH, A for ACTH, T for TSH, and then P for PTH. Okay, and then you can add the G on there for glucagon to make it a nice mnemonic. Okay. Great. Any questions so far? No? Okay. Okay, good. So we said that activated kinases are going to activate downstream proteins. They're going to activate some proteins, deactivate others, basically do this nice complicated cascade to lead to whatever effect it needs to have. So if you take the example of your TSH, right? This is the T of our flat pig mnemonic. TSH is going to bind to a G sub S receptor. That G sub S receptor is going to go to adenylate cyclase. I'm writing AC for adenylate cyclase. That's an enzyme. Adenylate cyclase is going to increase level of CAMP. And when you increase level of CAMP inside of thyroid cells, what happens is the thyroid cell will increase levels of thyroid hormone release. Increase T3, increase T4. Okay, and so that's in the thyroid. But if we changed all this around, if I just change a few of these letters, we can be talking about a totally different organ, right? So take away this TSH, we take away T3 and T4, and instead I'm going to talk about our, can I have my pen back? Thank you. I'm going to talk about our ACTH. All I'm changing is just the triggering hormone. So ACTH, released by the anterior pituitary, it's going to bind to a G sub S receptor in the adrenal gland. That G sub S is going to go to adenylate cyclase. It's going to increase levels of CAMP. Ultimately, we're going to get increased levels of cortisol. Okay? Increased levels of cortisol because ACTH activated a certain G sub S receptor. And so you can see that depending on the on the organ, even though it's the same G sub S protein cascade, you're having different effects depending on the organ. Okay, and so that's why it's nice to kind of have a good understanding of this process, because you can apply it to a lot of different organs. Okay, and so it's sort of helpful. So the PIP calcium signaling mechanism, this is for G sub Q receptors. And we said that ultimately in our G sub Q, G protein coupled receptors, the ultimate goal is to increase release of calcium. And so there's a few different names that we need to know here. Phospholipase C is the enzyme. Just like in G sub S, we talked about how we had adenylate cyclase as our enzyme. For G sub Q, we talk about phospholipase C as our enzyme. That instead of increasing level of CAMP, here we're increasing levels of IP3. And that IP3 ultimately is going to increase levels of calcium. Okay? Excellent. Okay. Great. And so another signaling mechanism is our cyclic guanine monophosphate. For some hormones, this is what it uses. So that's just, if you see that, just be comfortable with that. It's kind of like CAMP, very similar to CAMP, has the same type of mechanism. Last, you have some working without second messengers. So the insulin receptor is a tyrosine kinase. We're going to talk about it. That has autophosphorylation. And so for our insulin receptor, what we see is here is our cell membrane. This is an insulin receptor, and this is an insulin receptor. These are two different insulin receptors. So one of this is going to bind to insulin. One of this will bind to insulin. When each of these binds to insulin, what happens is on the inside of the cell, there's little enzymes that activate as soon as it binds to insulin. These enzymes will phosphorylate nearby other receptors. So this receptor is going to phosphorylate this is going to phosphorylate that, and ultimately all of this autophosphorylation is going to lead to the downstream effects that insulin has. Okay? But I think that I'm boring you at this point. We're going on 2 hours. Yeah. Endocrine is tough, and we've really just sort of barely started talking about, some of the things that we can see, but it's going to be more clear once we actually start talking about some of the actual systems. And so when we start getting into the pituitary and talking about how the pituitary works, growth hormone, how does growth hormone works, when you can actually, have something concrete you can put your hands on, it's a lot more easy to understand. Okay, so don't worry. It will start coming to you more easily when we meet again on next Monday. Okay.